Uh, Evening, everybody. Afternoon for some of you in the UK. So I'm a clinical oncologist. I trained in West Midlands, and then I've been here in Dubai for now over 6 years now. I've interest in GU cancers. Uh, so I'll be talking about updates in the management of prostate cancer. It's a big topic. We'll touch on the data, but I'll not go through obviously all the studies. Uh, I've also put some data for the updates from the last ESMO as well. So let's have a look. So just as a starter, when I talk about prostate cancer in UAE, uh, not everybody realizes how common it is in the West. So obviously it's the leading cause of death in men after the lung, but most commonly diagnosed cancer. But in UAE, it's not that common. It's number 5 in UAE. So this is just a schema. You've seen it many times. So prostate cancer patient progress through various stages. So if you catch them early, they have a localized disease. They could have a definite therapy with surgery or radiotherapy. Unfortunately, some patients will relapse and develop either a metastatic prostate cancer or sometimes just a biochemical relapse. But we are really getting good at detecting those biochemical relapse by doing better imaging and finding some metastasis. So this proportion of patients who have recurrence with no metastasis is smaller and smaller. I'll be today just talking about these two areas. So hormone sensitive prostate cancer and the MCRPC, which is a difficult area to treat. I put this slide just to show you the outcome patients were treated with ADT alone. This is a Kaplan-Meier curve from the Stampede trial. If you just look at the outcome of patients who are treated with ADT alone, is really poor. So an event will happen within 12 months if you treat them with an ADT alone. So that is something should not be done anymore. So that's just a message from this slide. So all of these patients who are fit for treatment should receive a combination of therapy. So ADT alone is no longer recommended. On the right side, data to show heterogeneity of the disease. So you have very variable prognosis depending on the site of metastasis. And we'll look into this further during the talk. So when I see a patient in a clinic, I really start to think about how I'm going to divide them into different groups because it's quite heterogeneous disease. It's really important for us to understand this as well. So all patients who present to you clinic with metastatic disease are not the same. And you can have patients with recurrent metastatic disease and then de novo metastatic disease. You have on one extreme patient with oligometastatic disease, and on the other extreme you have patient with high volume, and then there are patients between. And this oligometastatic disease definition is really changing depending what type of imaging you do. We have access to PSMA PET scans. We use quite a lot in these patients. In fact, majority of the time that's what we do, but not everybody has access. So definition for this oligometastatic disease may be variable depending on where you are and what type of scan you do. So when we look at this group of patients, obviously we have used this definition from Charted and Latitude. We don't all like these definitions because they are arbitrary, but that's the one we are left with. So you have patients with high volume and low volume disease based on Charted criteria, and then we also use the risk strategy. But in clinic, really, you use a combination of all these to try and put your patients into different categories. We use in the region here, in the Gulf, the NCC guidelines quite a lot. They also divide the patients into these different categories, and it's quite busy in terms of the choices available, but there's quite a overlap as well. So sometimes it is not easy to decide what would be the best treatment option, but we'll come to some sort of conclusions. So this is a summary slide, quite busy, but I just put all of the studies here. So on the top, you have the studies with doublet, mainly with hormones, second generation hormones, along with an ADT. And on the below slide, you have the triplet studies, two of them mainly, the PS1 and RSNs, and all of them have shown improvement in survival. And the median overall survival for these patients with a very heterogeneous group is 4 or 5 years now. So which is really exciting news for patients. But obviously you have patients who do worse than this, and some of them who do a lot better. That is depending on the risk category and the volume definition that we discussed earlier. So how are we going to select treatments for a patient from this, a big group of options available? So I have put this as a helping, so everybody should get an ADT, as we know, but majority will receive a second generation hormone in my clinic. So majority of the patients. What about triplet, where we have to add ADT? Obviously, we know about the volume criteria. That's what we use. But is that enough? Because the volume criteria is now used for second generation hormones as well, and it also works really well in those patients. So which patient should we be using triplet? So it's a difficult answer. But I put here patient, for example, with visual metastasis, patient with low PSMA. This seems to have the poor prognosis. What about histological and molecular features? We'll look at it in a minute. And I put poor PSMA uptake. This appears to be also a poor risk factor. What about radiotherapy to the primary? This is for a small group patient with the low volume disease, which is from the stamping has shown better outcomes. Again, you'll use the criteria as below. So in a simple form, if you're a patient where you don't think the chemotherapy is preferred, then in general terms, you have 3 options. Maybe 4 now. We'll look at the ESMO update. And if the chemotherapy is preferred, then you have 2 options: docetaxel and abiraterone, or docetaxel and darolutamide. Okay, few slides from the ESMO. I don't know trial. So this is last kid on the block. So this is again a second generation hormone. So darolutamide used in patients with hormone sensitive prostate cancer. Very similar trial designs to previous. So the patient with metastatic hormone sensitive prostate cancer, and they are stratified by visual metastasis and prior local therapy, and they were given 2:1 randomization by darolutamide 600 mg twice a day and placebo. Now this trial is done late, and by this time the standard of care had changed, and docetaxel at the time was the standard of care when they were recruiting. So they allowed patient with docetaxel in the study. But the trial is mainly done in countries where second generation hormones were not approved, because it's difficult to do these trials now. And these are the basic demographics and disease characteristics of these patients. The majority of the patients, 71%, had de novo metastasis, and the 22%, as you would expect from recurrent disease. High volume disease also is 70%, and low volume 30%. So these are the outcomes. One critique: the primary endpoint for this study is radiological progression-free survival, as opposed to the previous studies, which have put dual primary endpoints, including survival. So, but still, the trial is positive. A significant risk in reduction of progression, and so it may become, one of the treatments options available. Will it add anything? I'm not sure whether it will add anything further. We already have similar treatments available. Just a few words about arm K of the STEM-P. This was the metformin. You will remember this is one of the arms. So they have presented the results. So obviously this arm had been receiving treatments when the standard of care had been changing. So we had from ADT to ADT plus docetaxel, and then ADT plus second generation hormones. So it has recruited across those time, this arm. And not surprisingly, the primary endpoint of the study was negative. But there appears to be some numerical benefit in patients with high volume disease. How to interpret this data is open to discussion, but I don't think this will become a practice. They did mention that metabolic parameters actually improved with the use of metformin. So moving on, this was another interesting poster from the ESMO. And they looked at this tumor suppressant gene signature. They call it TSG by the use of RB1, P10, and T53. And this had they had previously validated this, and then they applied this on this cohort of patients from multiple centers, about 137 patients, and the signature was positive. You had at least two of them having a loss, so RB1, P10, and T53. Two of them had a loss, then you would call the positive signature. And then they try to correlate this with the emergence of castrate-refractory prostate cancer emergence. What they've shown that if you have TSG low positive, your risk of developing castrate-refractory prostate cancer is much higher. So this is something could be used in the future in clinical studies and also in the clinic to predict which patients may do have a worse outcome. And these are the patients who were treated with the second generation hormones, whether we can treat them better or whether we can use a triplet, for example. And they also looked at this signature and this correlation with an aggressive variant of prostate cancer, as we call it, and it seems to be correlated with that as well. So this signature may be useful in the future. Okay, so once you have chosen your therapy for the first line in the hormone-sensitive setting, and eventually majority of your patients will develop castrate-refractory disease. Why I put this again? Because all of these patients will progress differently. So patient with oligometastatic disease, progression will be very different than a patient with a high volume disease. And again, then there are a number of other factors that we've seen previously will play a role. So this group is a very heterogeneous group, and all of them have very variable outcomes. So not all CRP patients will have the same behavior, hence one size doesn't fit all. So that is something we need to think about in our clinics as well. So how can we define these variable clinical behaviors? I put some of the factors that I thought are useful, and I use them in my clinic. So what is the extent of progression? Is it oligometastatic progression? Or this is a widespread metastatic progression? Obviously, you'll have patients in between as well. But extent of disease, I think, is an important factor to be taken upon when we select the next line of treatment. Again, important consideration is what type of therapy was used in the first line. So doublet versus triplet, because that will have that will define your subsequent line of therapy and also give you an indication of how aggressive the treatment is. I think duration of response is also very important. So if you're a very short duration of response from the first line treatment, this patient's behavior is different than someone who had many years of good response from the treatment. So our choice of treatment will vary in the first line CRPC. I think molecular profiling is also emerging as an important decision-making tool. So we'll look at HRR mutations, MSI, and this TSG low marker that is in development as well. Another important thing to always remember is the neuroendocrine transformation. It's not that often we think about it. It's very few patients really undergo a repeat biopsy in prostate cancer, as opposed to, for example, breast cancer, where we biopsy on every progression almost. So I think in prostate cancer, we start to think about these patients with neuroendocrine transformation, because these are patients who have very poor outcomes. And how you will think about it by someone with a very low PSA and progressing, or someone with a poor uptake on the PSMA scan. And in this patient, I think we should consider biopsy of the metastatic site. And I put NCCN guidelines because the updated guidelines actually include small cell neuroendocrine component in the guidelines. So you have to think about it in a patient who is developing CRPC, because the treatment is different. So CRPC, I put as an unmet need. This is the data from US, where you would assume, first world country, and most of the treatments are available. But unfortunately, the annual all-cause mortality is 55%. And staggeringly, 1 in every 2 men do not actually receive a second-line therapy. And 1 in every 4 men will die without having received a second-line therapy. So this is it because the treatments are not available? Is it because our choice of therapy may not be good enough? So I think still a challenging disease to treat. So I put here 4 old trials. I just wanted to show you the survival outcomes of patients in CRPC. So in the trials, the best case scenario is 3 years overall survival, but on the look on the real world data, it's just around 2 years. So it's much shorter in the real world. So in the trials, um, and these trials were done at a time when we did not have second generation hormones or chemotherapy in the first line setting. So obviously these patients are already exposed to these agents, and so what the outcomes are now obviously different. But fortunately, we have better treatments available. So this is another way of looking at the data I showed you. So this is dropout of patients from the first to the second to third line therapy. So you see a significant drop in the number of patients who receive subsequent therapy. Hence, the choice of therapy in the first line MCRPC is very important. So these are the FDA approvals. It's quite busy, but we are quite fortunate in the fact that we now have lots of treatments available. But at the same time, it puts a challenge in terms of how to best choose these treatment options. These are the NCCN guidelines. It looks quite busy. It doesn't give you any guidance of how you would sequence these treatment, but just give you some information about which treatments may be eligible for which group of patients. But let's have a look at some of the data. So these are the major phase 3 trials which we base our current treatments on. So I've sort of divided them into pre-docetaxel setting and a post-docetaxel. And there's some studies which are either pre or post-docetaxel. So we have all these options currently available, from chemotherapy to secondary hormones to PARP inhibitor, and from radioligands available. Just few words about PSMA scan. I think it's a very important modality for patients with prostate cancer. It is just not imaging. It is more than imaging, because it can guide you metastatic directed therapy. For example, in a patient with polymetastatic disease with progress, you can identify patients who are candidate for PSMA targeted therapy. I think the PSMA scan is emerging as a very important tool for clinicians who treat prostate cancer. I think its use is obviously increasing day by day, but not everybody has access. But I think it's a very important tool to have. It can answer many important questions. And we know it's an actionable therapeutic target as well as diagnostic. And 80% of men with prostate cancer will have this expressed. So I've just put a summary of the 3 studies which are defining where we can use lutetium. So currently we have the approval post-docetaxel from the VISION study, and also from the therapy which compared lutetium versus cabazitaxel. The third study is PSMA4, which is pre-docetaxel. All of these studies, we have a positive radiological progression-free survival, but survival, overall survival was positive only from the VISION study. Therapy was not powered for this. PSMA4 is negative. There are critiques about these studies, whether the design of the study was good enough, because, for example, in VISION, the control arm is the switch of the hormone therapy, which we know is not very effective. Chemotherapies, we all know about this. We have docetaxel and cabazitaxel, and we're quite used to using them. And usually we use them for patients with symptomatic disease. And there's not much new data for me to share or discuss about chemotherapy. What about the sequential use of second-generation hormones? It's not something we should do routinely. Is it good for some group patients? We can discuss this. I just wanted to show you here the data. Look at just the control arm. So these are the control arms of the PROFOUND trial as well as the CARD trial. The control arms allowed the switch of the hormones from one second generation to other second generation, and you can see their outcomes are really poor. The median relapse survival is 3.5 months, so basically the next scan. So in general terms, you should not be switching from one second generation to a second, because it does not provide much benefit. What about mutations in the HRR gene, the DNA repair. That is also very important. So all patients with metastatic prostate cancer should undergo these testing. I believe this test should be done early on at the time of diagnosis of metastatic prostate cancer, and the tissue is fresh. And even if you want to do a liquid biopsy, you have enough circulating ctDNA to give you a better result. So I think we should not wait until the development of CRPC to have this done. And you can see 25% of these patients, our patients, will have one of those mutations. And it's important not just because and the targeted treatment is available, but because these patients unfortunately have poor prognosis. So if you do the tumor testing, you can detect both somatic and germline, but obviously you can do a separate germline if you want it for other reasons, for example, family. So I've put out this here just to show you the poor outcomes of these patients when compared with wild type disease. So patients who have BRCA mutation, they have a poor outcome as opposed to wild type disease. But fortunately, we do now have targeted therapies available against this. You know how the PARP inhibitors work. So I'm not going to this. So I just want to show you. Obviously, we previously had data for single agent PARP inhibitors, for olaparib, for example, in patients with BRCA mutation, where it showed the maximum benefit. But now we have three large studies which are looking at combination of a PARP inhibitor with a second generation hormone, and these studies have improved outcomes for patients. Obviously, the challenge here is that majority of these studies, the initial treatment did not include a second generation hormone, which has become a common practice now. So how to put this in practice now while we've already used the second generation, or the patient has progressed on a second generation? And there's always a debate about this. So the question is whether we should use a single agent PARP inhibitor or a combination, or in other terms, you can talk about sequential therapy. There's not much data about this, but I just show you a small phase 2 study by Mahouse, and this is a BRCA study. So she looked at this sequential versus upfront combination. So this is a phase 2 study on patient with MCRPC with a prior exposure, no prior exposure to abiraterone or PARP inhibitor. And the arm included abiraterone on its own. The arm 2 was olaparib on its own, and the arm 3 was a combination. And what she has shown actually is very interesting. Numbers are small, but obviously it gives you some idea. So when you look at the outcomes, median progression-free survivals, Abi alone is 11 months, olaparib alone was 11 months, but in a combination arm, it was not reached. And we see a higher PSA response. And when we look at 12 months progression-free survival, it's almost double at 95% as opposed to in 40s with a single agent. So it appears that if you're a patient with an HRR mutation, combination probably is better than a sequential approach. So how can we address this patient diversity? I've just put a few things that you should think about when you see the patient in the clinic. So you should look at think about neuroendocrine component, think about extent of progression. If you can do PSMA scan, I think it's really good. It can give you understanding of what type of disease you're dealing with. You should have HRR mutation results available really when you're making this treatment decision. Also think about wider molecular profiling, as we discussed. For example, low TSG score, patient comorbidities, and patient choice is also important, an outcome to previous therapy. Just a few words about ESMO update in MCRPC. So this is a phase 3 study. I think it's a very important study. This study looked at combination of radium with enzalutamide versus enzalutamide alone in patients with asymptomatic or mildly symptomatic CRPC. Now, radium is not available in the Gulf, but you have this available in UK. So this study asked the question of whether we can add radium-223 to enzalutamide. Obviously, previously there had been concerns about fractures, for example, So the primary endpoint of the study here was radiological progression-free survival, which is positive with a hazard ratio of 0.69, favoring the combination. So it's a positive study. I think it can be a practice-changing study. And what about overall survival? With 80% of maturity here, again, in terms of median months, 42 versus 35 months, so it's positive. With the hazard ratio 0.69, again, positive. They've reported toxicity, including fractures. So there's a small increase in the fracture rates. Obviously, you would want to use bone modifying agent for these patients. Promising triple upfront. I think I'm quite excited about this. This is a use of lutetium in the upfront setting, the time of diagnosis. Now, this trial used docetaxel as a partner, which we're not using for majority of patients now as a partner. But it's just a very important study, because I think in the future we'll have studies with the second generation hormones. So they've compared basically use of lutetium along with chemotherapy in patients with newly diagnosed metastatic hormone sensitive prostate cancer. So 6 cycles of docetaxel was used along with 2 cycles of lutetium, and the control arm only had the docetaxel on its own. And these are the primary endpoint, which was the undetectable PSA, and the secondary endpoint included radiological progression-free survival and overall survival. So we had the early results of this, and it showed that undetectable PSA at 48 week was 41% with the combination arm versus only 16%, which was with the odds ratio of 3.88. So quite encouraging early results. So I think there are a lot more studies required in this setting. I think it looks encouraging that we may be able to use PSMA therapy upfront. So with this, I'll conclude my presentation. Just few take-home messages. So we are fortunate that we have significant progress in the range of options which are available for these patients with advanced prostate cancer. I think it's important to remember the heterogeneity of the disease and individualizing the treatment for patients. And hence, the treatment decisions are complex. And hence, I think discussion with colleagues and MDTs are important. The challenges still remain in terms of sequencing, but personalized therapy would be helpful for certain group of patients. Precision medicine is reshaping the management, and it's also important to remember the drug toxicities. And with this, I will conclude my presentation, and thank you very much for your time.
Thank you. That's a wonderful talk, Dr. Tirmizi, and I think it was very, very informative for me as well. So we have got a couple of questions in the chat section. So first question is from Dr. Butt. He's simply asking, do you think PSMA lutetium will leapfrog docetaxel after ARSI use?
So can you ask the question again? So I didn't get it.
Sorry. So the question is, do you think PSMA lutetium will take over or will leapfrog docetaxel in next few years after first-line ARSI use?
I think so. So currently the approval is post-docetaxel, but we have I've shown you the data for pre-docetaxel as well. So someone who is not fit for chemotherapy or a patient who declines chemotherapy, I think it is currently an option. So in the Gulf, we can use it for patients where we think the chemotherapy is not the right treatment for this patient because of whatever medical reason, or if the patient declines chemotherapy and their PSMA scan is positive. So we're using in certain group of patients. Obviously, this is not the current label, but I think it is likely that this therapy will come early, and it's much better tolerated, as you would have seen as well, if you use it pre-chemotherapy.
That's good. Thank you. And so the other question is, at what point would you check BRCA mutation?
I would like to know it as early as possible. I think it's important to know this because it does not only tell you your sequence of therapy, but also informs you the prognosis of patients. I think it is important to have this information. And I would rather do it on a fresh tissue as early as possible. If you want to do a liquid biopsy, you should also do it very early on, because majority of patients get a so nice response from the first line therapy. Often you see a complete response, and then when they develop CRPC and you do not have a fresh tissue, or you don't have a tissue at all, and you try and do a liquid biopsy, you're not going to get much circulating ctDNA. So I think early on is better.
All right. Okay, that's good. Thank you. So I think in the UK as well, practice varies, but now where I'm working, the metastatic patients straight away. I mean, if they're high risk metastatic, they just go for BRCA testing straight away at presentation. So and another question just popped in. So what is your experience using ARSIs in 85 plus patients? If the patient is 85 plus, so yeah.
Very good. I have had no problem, as long as I think if you have a patient who can come to the clinic walking, I think he can tolerate an ARS. That's what a general, I can tell you. But majority of the patient I've been able to use it. Obviously, I think what I've seen is obviously we're using it for longer term now. In CRPC, we were using it for a very short period of time. Because disease will progress, but progression is much less. Now you're talking about majority of the patient crossing 2 years on these drugs. So you start to see cardiovascular toxicity. You start to see memory issues. So I think that is something to look out for. What I'm doing for those patients who I get a very good response, I de-escalate. If I see a hint of a problem, or if the scan is really good, for someone who's really, elderly, you already control the disease, so I think you can de-escalate, and that's what I've done for patients here.
So one last question. I think this will be the last question for this session. In Gulf, I think someone is asking from Gulf. In Gulf, can you use Abi plus olaparib in metastatic hormone-sensitive prostate cancer?
It's not approved yet in this setting. The approval is currently in the CRPC. Yeah, so we don't have PARP inhibitor approval in the hormone sensitive. It may be coming, but I think it may not be positive, the data, because the majority of the benefit is coming from the secondary hormones, and the PARP inhibitor benefit is not that huge. And after all this hype for so many years, the outcome is not as good as we were hoping. But currently in CRPC, I don't think it's approved hormone sensitive.
All right, okay. That's great. Thank you so much, Dr. Tirmizi. It was a really informative session, and now we will move on to Dr. Faisal Azam, who is there as well. So, and thank you. So we will start with Dr. Faisal Azam's presentation. So just let me introduce you slightly. Dr. Azam is currently a consultant medical oncologist in Dammam, Saudi Arabia, and he has previously been trained in the UK. And he has been working as a consultant in Clatterbridge Cancer Center as well. So all over to you, Dr. Faisal Azam.
Bismillah ar-Rahman ar-Rahim. Assalamu alaikum, everyone. Thank you very much for the introduction, and thank you for organizing this meeting and asking me to talk about the renal cell carcinoma. Yeah, so you already introduced me. I'm a medical oncologist in Dammam currently, and I've been trained in Oxford and in Clatterbridge in Liverpool. I have been a consultant in Dammam for last 10 years. So today I'm going to talk about the management of advanced renal cell carcinoma. Specifically, I will just talk about how to select treatment. You probably know what are the treatments available, but how to select those treatment is the main thing. So I have 3 patients, real-time care patients. So I will present those and will discuss how we have selected treatment for those patients. So that will be all the up-to-date treatments, and the evidence behind those treatments will be discussed. So as we all know, that the clear cell carcinoma is the most common kidney cancer, with more than 70% cases, and the other rare types are papillary, chromophobe, collecting duct medullary carcinoma. Right. Okay, so the staging, stage 1 is 7 centimeter or less, stage 2 more than 7 centimeters, stage 3 is lymph node involvement with or the venous involvement or the big veins involvement, and Gerota's fascia while stage 4 is more advanced disease. The survival also depends on the stage, as you can see here. Stage 1, 5-year survival is 81%, but it's the stage 4 disease where the 5-year survival is only 5% or 10%, and that is where the unmet need is, and you see most of the trials are done for those patients for that reason. So for metastatic disease, we stratify those patients into favorable, intermediate, and poor risk disease, and the most common criteria used is IMDC criteria. Well, this is the criteria which was started in the era where when we did not have immunotherapy. It was mainly TKI. So it's not the best criteria to use for the immunotherapy, but that's the only criteria we have, and that is why we are still using it. So the criteria we use are the performance status, time from the initial diagnosis to the targeted therapies or targeted treatment, hemoglobin, calcium, platelet counts, and neutrophil count. If the patient have none of these risk factors, that is labeled as favorable risk disease. If they have 1 to 2, that is labeled as intermediate risk disease, and 3 or more than 3 are poor risk disease. And you can see here, the overall survival depends if the patient have the favorable risk disease, intermediate, or poor risk disease. The best survival is with those patients who have favorable risk disease. And as I said, that this is the era when we did not have immunotherapy. So this basically does not help us much, but still we are using it to decide about the treatment, or at least to know about the prognosis of these patients. So for the first patient is a 46-year-old young patient who presented with loin pain, and a CT scan reported as left renal mass, no distant metastases. So as no distant metastases, he underwent radical nephrectomy, and pathology reported as high-risk disease, clear cell carcinoma, PT3, lymph node positive disease, and sarcomatoid features. So lymph node positive and sarcomatoid features are poor prognostic features. Although this patient is not metastatic and it has removed, but he is high-risk disease. So the question is, how will we manage this? Basically asking about the adjuvant treatment. Would you just do follow-up pembrolizumab, sunitinib, ipilimumab plus nivolumab, or nivolumab? So the guidelines recommend to do either surveillance or give pembrolizumab for stage 2 or stage 3 disease if they have high-risk features. And the high-risk features, as mentioned here, is grade 4 disease or sarcomatoid features for stage 2 disease. And for stage 3 itself is a high risk anyhow. So these are the patients who can benefit from the adjuvant pembrolizumab for 1 year, or surveillance is one of the options if they don't have the high-risk features. So the evidence behind this is Keynote 564, a phase 3 study with more than 900 patients reporting as disease-free survival and overall survival benefit with pembrolizumab in adjuvant setting. There are many trials for renal cell carcinoma where they've tried atezolizumab in iMotion 010, ipilimumab plus nivolumab in Checkmate 914, and Prosper RCC have tested nivolumab in adjuvant setting. All these studies, the primary endpoint, as you see, is disease-free survival or relapse-free survival, and these studies were negative and they never became the standard of care. STRAC was the study where they tested sunitinib in adjuvant setting versus placebo, and the study was positive with hazard ratio of 0.76, but no overall survival benefit, and there was significant toxicity, and that is why it never became a popular choice among the oncologists all over the world. So the only adjuvant treatment is pembrolizumab, which has shown to improve the overall survival in renal cell carcinoma, and that is why it is the new standard of care for our patients. So this is the Keynote 564 phase 3 study where they randomized patient to pembrolizumab every 3 weeks for 70 cycle or 1 year, and the control arm was placebo every 3 weeks for 17 cycles. All these patients had nephrectomy. They had if they had oligometastatic, they had metastatectomy also, and they had high risk or intermediate high risk disease. The definition of intermediate high-risk disease is PT2 with grade 4 or sarcomatoid features, or PT3 with any grade. This is intermediate high risk. High risk were PT4 any grade or lymph node positive disease, and M1NED was defined as those patients with oligometastases along with nephrectomy. They had metastatectomy also done. So the study was positive in terms of the disease-free survival, which was the primary endpoint. At 24 months and 30 months, the benefit was seen for pembrolizumab. As you can see, at 24 months, the hazard ratio was 0.68, and 30th month, at 30-month analysis, it was 0.63 again, favoring using pembrolizumab as compared to follow-up only, although the median was not reached. This benefit was seen in all the patient, intermediate high risk, or M1NED, but the benefit was more in patient who had oligometastases and metastatectomy was done with the hazard ratio of 0.28. Then, as I mentioned to you, pembrolizumab is the only drug which has shown to improve the overall survival in patients with renal cell carcinoma in adjuvant setting. Hazard ratio of 0.62 was reported, and that is one of the reasons now that patient with a high risk, intermediate high risk disease or oligometastases where the metastatectomy was done with nephrectomy, then it's now a new standard of care to use pembrolizumab for 1 year every 3 weeks. Then moving on to metastatic renal cell carcinoma, we have 4 different combination of treatment. First one is IO plus IO, immunotherapy plus immunotherapy, ipilimumab plus nivolumab. Checkmate 214 was the study, and then we have 3 different combination of using IO plus TKIs, pembrolizumab plus lenvatinib, pembrolizumab plus axitinib, and cabozantinib plus nivolumab, all phase 3 studies. And control arm in all these studies, as you can see, is the sunitinib. So definitely combination of either IO plus TKI or IO plus IO is better than single agent sunitinib. So if you have a patient with metastatic renal cell carcinoma, first line treatment is no more single agent sunitinib. It should be, the combination should be considered. And that has shown in all the studies in first line that combination is better than sunitinib. So we are no more using sunitinib in any patient with first line metastatic renal cell carcinoma. Now then depends which combination would you use. Would you use immune checkpoint inhibitor with immune checkpoint inhibitor, or would you use immune checkpoint inhibitor with TKI? That is the big question which I am going to discuss today. So my second patient is 52-year-old patient who had renal cell carcinoma treated with nephrectomy, and it was PT3 and 0, so intermediate high risk disease. And this was the time when we did not have any approved adjuvant treatment, so a patient was put on surveillance or follow-up only. And 2 years into a follow-up, patient developed small, low-volume lung metastases. Biopsy was done, and it proved to be a clear cell carcinoma. So patient was asymptomatic, low-volume disease, and he was not keen on treatment. So we decided, or we agreed with the patient that to continue with surveillance. He was doing very well. 14 months later, a scan showed very slight progression of disease. Now the lung metastases has grown to 1 centimeter by 1.5 centimeter. They were very small, but new mediastinal lymph nodes. His performance status is still very good. And apart from low hemoglobin, other risk factors were not seen. So this patient have an intermediate risk metastatic disease. So we are talking about the first line treatment in a patient who have a very slow growing, low volume, lung only metastases, and there is now new mediastinal lymph nodes. So the question we have it now, would you continue with surveillance? Because we have been doing surveillance for this patient for nearly 1.5 years or 2 years, and his the growth is quite slow. Or would you like to give IO plus IO, or would you like to give IO plus TKI or sunitinib? Well, sunitinib is not the option anymore because all the trials have shown that combination is better than sunitinib. So the question is, if you are giving treatment, would you give IO plus IO or IO plus TKI? So what we decided that we gave ipilimumab plus nivolumab for 4 cycles, and then nivolumab every 2 weeks. 1 year after starting the treatment, patient had complete response in lung metastases. He's currently on nivolumab alone. He's doing very well. So looking at the guidelines, you can see favorable risk disease, the combination of axitinib plus pembrolizumab, cabozantinib plus nivolumab, and lenvatinib plus pembrolizumab are all recommended as category 1 preferred treatments. Ipilimumab plus nivolumab is also recommended for favorable risk disease. I must say that this was not included. Ipilimumab plus nivolumab was not included in the favorable risk disease till this year. Now, this is very recently has been included because after 8 years of follow-up, this combination has shown to improve the overall survival. For poor risk and intermediate risk disease, our patient was intermediate risk disease. All these combinations are recommended, including the cabozantinib as a single agent is also approved. So as I mentioned to you, we have 4 phase 3 studies. Checkmate 214 led to approval of ipilimumab plus nivolumab. Keynote 426 phase 3 study again led to approval of axitinib plus pembrolizumab. Checkmate 9ER led to approval of cabozantinib plus nivolumab, and CLEAR study led to approval of pembrolizumab plus lenvatinib. Control arm for all these studies was sunitinib, and all these studies has shown to improve the outcomes in patient with metastatic renal cell carcinoma in first line. So we gave ipilimumab plus nivolumab because of Checkmate 214, which is a phase 3 study where they randomized patient to receive ipilimumab plus nivolumab for 4 cycles, followed by nivolumab, and the control arm was sunitinib as a standard dose, 4 weeks on, 2 weeks off. And the study has shown improvement in overall survival. The primary endpoint was overall survival in intermediate or poor risk disease. And you can see here at 17 months, 30 months, and 42 months of analysis, the overall survival benefit was seen, favoring using ipilimumab plus nivolumab as compared to sunitinib. How about favorable risk disease? And you can see here at 17 months, 30 months, and 42 months, no survival benefit. Hazard ratio of 1.45, hazard ratio of 1.22, and hazard ratio of 1.19. So no benefit of using IPI plus Nivo in favorable risk disease up to this point in terms of overall survival, while it was significantly beneficial in terms of overall survival in intermediate and poor risk disease. Then this year, they have presented a data after 8 years of follow-up, and they have reported that in intermediate and poor risk disease and ITT population, the benefit of overall survival remained the same as in the previous analysis. But in the favorable risk disease, things have changed. Now they can see the overall survival benefit with EP plus Nivo, which was not seen before in the previous 3 analyses. And you can see the hazard ratio is 0.82. The median overall survival for favorable risk disease was 77.9 months for Nivo plus EP as compared to 66.7 months for sunitinib. So after long-term follow-up in the favorable risk disease, overall survival is seen, and that is why NCCN guidelines have now included this combination also in patients with favorable risk disease. How about the progression-free survival? The results are similar. For intermediate and poor risk disease, the benefit is in favoring using IP plus Nivo as compared to sunitinib. But in favorable risk disease, like in previous analysis, there was no benefit with EP plus Nivo. You can see here hazard ratio is 1.76. So no benefit in terms of progression-free survival if you are using EP plus Nivo as compared to sunitinib. How about objective response rate? You can see in ITT population and intermediate poor risk disease, the benefit is seen with Nivo plus ipilimumab 39% versus 33% in ITT population, while 42% versus 27% favoring EP plus Nivo in intermediate and poor risk disease. But here in favorable risk disease, again, the objective response rate was better with sunitinib, 52%, while with Nivo plus EP is 30%. So no benefit again in objective response rate for favorable risk disease. And again, progression-free survival was also not beneficial in favorable risk disease after 8 years of follow-up. Those patients who have responded to the EP plus Nivo, the duration of response was significantly longer. You can see here in intermediate and poor risk disease, the median duration of response was 82 months as compared to only 19.8 months with sunitinib. So immunotherapy, when you use to the right patient, and if they respond, their responses are usually long-standing and quite long. in a favorable risk disease, although the objective response is not favoring EP plus Nivo, but those patients who responded, you can see here, the median duration of response was more than 61 months with EP plus Nivo as compared to only 33 months with sunitinib. So definitely better duration of response. Then they looked into the different sites of metastases, lung, liver, and bone metastases. And you can look at the hazard ratio in lung metastases, liver metastases, and bone metastases for overall survival. It's beneficial in patients who had Nivo plus ipilimumab as compared to sunitinib, but progression-free survival for lung metastases and liver metastases seen, but not in the bone metastases. So it seems like patients who have soft tissue metastases or visceral metastases, they benefit from IO plus IO, but bone metastases do not benefit from ipilimumab plus nivolumab in terms of progression-free survival, but in terms of overall survival benefit has been seen. Now, IO plus IO or EP plus Nivo is usually very well tolerated, and you can see here, most of the side effects are usually in the first 6 months or at least first 12 months, and then as the time passes by, the side effects get less and less. So EP plus Nivo is one of the combination recommended for all the patients, and specifically for those patients who have intermediate and poor risk disease. And you can see here, because of the long-term follow-up after 8 years shown to improve overall survival, progression-free survival, and objective response rate in intermediate and poor risk disease. But for favorable risk disease, there was an overall survival benefit seen after 8 years, but before there, even that benefit was not seen. Hazard ratio 0.82, but even after 8 years, no benefit in progression-free survival and no objective response rate benefit in favorable risk disease. But because of the overall survival benefit, it is recommended even in the favorable risk disease to use in first-line treatment. So moving on to our third patient, which is a 56-year-old teacher, very anxious, presented with abdominal pain, and he had a very large renal tumor, left-sided renal tumor, no metastases, underwent nephrectomy. It was PT3 grade 4 disease, so high-risk disease, and again, it was 2017. We did not have any adjuvant treatment. So we just carried on with the follow-up, and 5 months after surgery, he presented with 2 pulmonary nodules, 2 centimeter and 1.2 centimeter. PET scan was done. That reported as FDG, avid lung nodules, no disease anywhere else. So he was offered metastatectomy, but patient refused. So he was offered systemic therapy. He refused. So the only option left was surveillance for him. So we started surveillance, and we have booked him in a scan in 3 months' time. But unfortunately, just after 2 months of starting surveillance, he presented with extreme shortness of breath. He could not complete sentences. His performance status was 0 when he was seen 2 months ago, and now it is 3. He has significant pleural effusion, as you can see on a chest X-ray, and thoracentesis was done for this reason. Pleural cytology was negative. Pleural biopsy was done at that time, and that confirmed it to be metastatic clear cell carcinoma. This time, he agreed on treatment. After thoracentesis, we did a PET scan. It reported multiple bilateral lung and pleural metastases, and also liver metastases has been reported. His calcium was high, hemoglobin low, and performance status 3. So more than 3 risk factors mean he has a poor prognosis, metastatic renal cell carcinoma. So we decided to start him on pembrolizumab plus lenvatinib, and he responded very well to the treatment. Just in a matter of 3 months, clinically, he became asymptomatic. Performance status improved to 1, and a PET scan responded with significant response and minimal residual disease in the lungs. The 8 months into the treatment, he is doing very well, and he had near complete response. He is back to his work as a teacher, and he's doing very well currently on the treatment and doing very well. So why have we decided to give him IO plus TKI? So you remember, when he refused the treatment, within 2 months, he progressed. So that means the progression was significant. This is different than the first patient where we gave ipilimumab plus nivolumab, where the progression was very slow. Here, the progression was very fast. And you can see here, when you use IO plus TKI, the responses are significantly higher with this combination as compared to IO plus IO or single agent TKI or single agent immunotherapies. And that is the reason we prefer to give IO plus TKI to those patients who have a rapid progressive metastatic disease. So I'm not going to go into detail of these studies, but I'll just briefly give you an overview of all those studies. Keynote 426 was a phase 3 study led to approval of axitinib plus pembrolizumab. Checkmate 9ER led to approval of cabozantinib plus nivolumab. And CLEAR is a phase 3 study led to approval of lenvatinib plus pembrolizumab. Luckily, we have all these three combinations approved in our center, and we are using all these three combinations of IO plus TKI, and also we have ipilimumab plus nivolumab. So if you look into all these three studies, the inclusion criteria of these studies were similar, and the control arm was similar. So the design of all these studies were similar in terms of inclusion criteria and control arm. Then looking at the baseline characteristics, again, for Checkmate 9ER, CLEAR study, and Keynote 426, they were similar. They've included patients with favorable risk disease, intermediate risk disease, poor risk disease. They have included patients with more than 2 organ metastases, liver metastases, and lung metastases. And if you look at the numbers also in all these studies, they are more or less similar. So the design was similar, patient population was similar. So we should expect the results should also be similar. So looking into the results, this is not direct comparative comparison of these trial, but I'm just putting side by sides the results of these studies. So Checkmate 9ER of cabozantinib plus nivolumab reported median progression-free survival of 17 months with the cabozantinib plus nivolumab versus 8 months with sunitinib, hazard ratio of 0.56. With axitinib plus pembrolizumab in Keynote 426, median was 16 months as compared to 11 months with sunitinib, hazard ratio of 0.68. So more or less similar result in both these two studies. And then we have CLEAR study of lenvatinib plus pembrolizumab reporting median progression-free survival of 23 months versus 9 months with sunitinib, hazard ratio of 0.42. So if you look at the sunitinib arm in all these three studies, the median progression-free survival is more or less similar. But the combination of IO plus TKI seems to be the pembrolizumab plus lenvatinib have reported better. Although, as I told you, the design of the study is similar, and also the baseline characteristics were more or less similar in all these studies. Then objective response rate for cabozantinib plus nivolumab, it was 56% with 12% complete responses as compared to 28% with sunitinib. For axitinib plus pembrolizumab, it's 60% objective response rate with 9% complete responses as compared to 40% with sunitinib. And again, it's more or less similar if you look at these two studies, but CLEAR study of lenvatinib plus pembrolizumab have significantly higher objective response rate reported, 71% with 17% complete responses as compared to 36% with sunitinib. So again, lenvatinib plus pembrolizumab seems to have a better objective response rate or higher objective response rate in their phase 3 study. How about overall survival? For cabozantinib plus nivolumab, the hazard ratio was 0.56. With axitinib plus pembrolizumab, hazard ratio was 0.68. And again, lenvatinib plus pembrolizumab in CLEAR study, hazard ratio of 0.42 has been reported in these studies, which is significantly higher than the sunitinib in all these studies. Looking at the 12-month overall survival and 24 months overall survival combination, treatment of EP plus Nivo or IO plus TKI definitely is better than sunitinib. But if you look at the IO plus TKI, all combinations seems to be better even than IO plus IO. And at 24 months also, you can see lenvatinib plus pembrolizumab 79%, overall survival at 24 months standing out. But overall combination seems to be better than sunitinib alone. Objective response rate, looking at different trials. So Pembro plus lenvatinib, 71%, Nivo plus cabozantinib, 55%, Pembro plus axitinib, 60%, while Nivo plus ipilimumab, 39%. And the most interesting bit, which I like the most, is here, rate of progression of disease for pembrolizumab plus lenvatinib, only 5%, nivolumab plus cabozantinib only 6%. That means if you use any of these combination of IO plus TKI, most of the patient, that is more than 95% patient, would respond and not progress. So which is amazing, isn't it, when you see for metastatic renal cell carcinoma, while for ipilimumab plus nivolumab, the progression of disease was reported and 18% as their first response. So just putting side by side all these trials and showing you, so if you look at the hazard ratio for progression-free survival, the best hazard ratio reported with lenvatinib plus pembrolizumab, 0.47, objective response rate of 71% with 18% complete responses, again, better than any other combination. And the progression-free survival, overall survival, sorry, remain more or less similar. If you look at the hazard ratio is similar in all these studies here. But this is at the cost of more toxicity. Adverse event leading to discontinuation in CheckMate 2 and 4 for EP plus Nivo was 23%, with axitinib plus pembrolizumab 10%, with cabozantinib plus nivolumab, it is 7%, but 37% has been reported with lenvatinib plus pembrolizumab. So definitely more toxic, although the responses are much higher with this combination. So grade 3 or more treatment-related adverse event with cabozantinib plus nivolumab, 65%, with axitinib plus pembrolizumab, 67%, but significantly higher with lenvatinib plus pembrolizumab, although you see higher responses, but at the cost of more toxicity. And then quality of life in all these studies reported to be not inferior than the sunitinib alone in all these studies. So just to conclude, for renal cell carcinoma with metastatic disease, intermediate poor risk disease, we have ipilimumab plus nivolumab, pembrolizumab plus lenvatinib, pembrolizumab plus axitinib, and cabozantinib plus nivolumab, all showing improvement in their outcomes, which is progression-free survival, overall survival, and objective response rate as compared to sunitinib. So any of those can be used. Then in the favorable risk disease, ipilimumab plus nivolumab after 8 years of follow-up shown to improve overall survival, but not progression-free survival or objective response rate. We have IO plus TKI, pembrolizumab plus lenvatinib, pembrolizumab plus axitinib, and cabozantinib plus nivolumab show no improvement in overall survival for favorable risk disease, but progression-free survival and objective response rate benefit has been seen. So there's a clear survival benefit with combination therapy versus sunitinib. The question is, which combination would you use? Would you use ipilimumab plus nivolumab? If you are using that, that is because it has lower toxicity, better quality of life, durable but slow responses. So those patients who have a slow growing disease, soft tissues like lung metastases, lymph node only metastases, this would be my choice of treatment. But those patients who have a fastly growing disease or a high burden disease, then IO plus TKI is better. I have shown you the results, but they have higher toxicity, higher and rapid objective response rate. And among those combination, lenvatinib plus pembrolizumab has shown to have a better objective response rate, but significant toxicity of 82% of grade 3 or more toxicity reported in CLEAR study. Thank you very much. That was just a brief summary of first-line treatment of metastatic renal cell carcinoma. So we can take the question if
Thank you, Dr. Faisal. It's a really great and really informative session. I've stopped doing renal cell, but still it was, very fascinating. So we got few questions. First one is, do you think subcutaneous nivolumab will replace intravenous in renal cell carcinoma soon?
Subcutaneous nivolumab not approved yet. So currently still the approval the approval is for IV. It can, if we have some comparison with IV. So it can, yes, like we did Herceptin, which has changed the practice to subcutaneous. So it is more convenient. But currently, as we are, the still approval is for the intravenous rather than subcutaneous.
All right, and another couple of questions. One question is, with the lenvatinib pembrolizumab, the criticism is it has more favorable patients and less poor risk patients. So you think it is the reason for better outcome survivals?
It could be if you see the favorable risk disease, there's a slight differences actually, but all these trials have included patient between 22 to 30%. So not much difference, slight difference in the inclusion criteria of the favorable risk disease. I don't think so that is the major factor. Maybe that is one of the factor, but not the major factor because all these studies have included patient and they were more or less similar between the 22% and 30% between these studies.
All right, and the last question is, can we offer IO plus TK in patients with brain metastases? And what would be your approach for this year?
Yes, we can. We can offer IO plus TKI. They usually do not behave very well, but we have used it in patients. The overall with the renal cell carcinoma and brain metastases, the prognosis is poor, but it can be offered, and especially when you use radiotherapy. After radiotherapy, the blood-brain barrier is broken, so it is one of the treatment option, of course.
Yes. All right, thank you. So I think due to time constraints,
if you allow me one quick question.
yeah, go on, please. But please, quick.
Oh, yeah. I'm sorry for that. I have a small break for prayer. Actually, this prayer time now. So, first of all, one small or two small comments and then questions.
Please.
So, first of all, my name is Dr. Zafar Ali. I met Dr. Faisal in Saudi Arabia while I'm working in King Fahad Medical City. And he's just joined King Fahad, the mom. So
Yes.
while he's telling he's 10 years now in Saudi Arabia, so something very much,
Thank you.
how time the pass. Now I'm in UK, still he is in Saudi. My
Yes.
quick question, Dr. Faisal, about to be your third scenario, the patients with, and you start with lenvatinib with the pembrolizumab. So now the pembrolizumab's adjuvant setting is sometimes high risk patient is standard of care. So if the same patient, you start the pembrolizumab at the adjuvant setting, so what will be the choice? Or if someone have already pembrolizumab in adjuvant setting, so what will be options? We know that, but can we use the pembrolizumab again in the metastatic setting or no? To make.
That is a very good question, actually, and this is the big question usually in the discussion in different meetings. So when you use pembrolizumab, and if we have metastatic disease after a long time, they say you can, yes, you can try, although there is no evidence of using it, and that will help. We have more of the evidence of not using immunotherapy after Contact 03 study, where it shows if the patient is already on immunotherapy and they progress on immunotherapy, we should not be using it. But that's a different scenario, where if you've used the pembrolizumab in adjuvant setting and you have more than 1 year before the patient develops metastatic disease, I think we can use it, although the evidence is not there, but we can be using it. But those patients who progress earlier, I don't think so we should be using immunotherapy again. We should be using TKIs. Cabozantinib have a good evidence of using after immunotherapy. And we, in our practice, actually, in our hospital, we are using cabozantinib as single agent.
Great, thank you. So I think we don't have any time for any more questions for this session. But just a quick comment, quick question with all these trials. Do you have any data how many patients crossed over to the intervention in all these trials? Because we know, I mean, from very early on, we came to know that sunitinib is less effective than all the combinations. Did you have any data of all of these trials? How many patients crossed over to intervention?
That has
did they
been
take
reported.
into consideration?
Yeah, that has not been reported actually, that how many patient has crossed over from sunitinib to receive combination actually. So I'm not sure. I don't have any record of it, or I have not come across any of the data.
All right, okay, that's great. Thank you so much. So it was sorry for not taking the more questions for this session. We will move on to the next session, which is urothelial. And again, Dr. Faisal is enlightening us on that. Thank you.
All right, thank you very much. So a very quick overview of the urothelial carcinoma. Again, a very interesting topic. It was supposed to be Professor Hussain, but I think he cannot do it, so I will do it. So I'm just gonna briefly give you an overview of how we should be treating the metastatic urothelial carcinoma. So as we all know that this is the metastatic urothelial carcinoma, which has poor prognosis with 1-year survival of 33%, 5-year survival of only 10 to 15%. And with the chemotherapy which we have been using, the median survival is around 15 months. The poor prognostic feature, which is very important here, I mentioned, is bone metastases, liver metastases, and poor performance status. These are poor predictive of poor response, and they're associated with a very poor survival of only 4 months. So approximately 200,000 deaths happens due to urothelial carcinoma annually. Platinum-based chemotherapy has been a standard of care for many decades. And then we had immunotherapy. Evolumab was approved in those patients who does not progress on the platinum-based chemotherapy. And then we have seen that immunotherapy is effective, and before immunotherapy, platinum-based chemotherapy was effective. And so the combination treatment was introduced. So I'm going to discuss those, but just very briefly to tell you how we treat the urothelial carcinoma. For those patients who have non-invasive urothelial carcinoma, it's the TURBT, which is the treatment, and then intravesical chemotherapy is given immediately or within 24 hours of the TURBT. And then after that, it's the maintenance BCG or mitomycin in patients who have a high-risk disease for relapse. For muscle-invasive disease, it's a new adjuvant cisplatin-based chemotherapy followed by cystectomy. I'm saying cisplatin because if the patient is not eligible for cisplatin, they should not receive any more any other chemotherapy like carboplatin or immunotherapy. They should go straight for cystectomy, and then adjuvant chemotherapy can be offered to those patients. For metastatic disease, it's the platinum-based chemotherapy, which has been the standard of care for a long time. And now more recently, enfortumab vedotin, which is an antibody drug conjugate with pembrolizumab, has been reported. In ESMO this year, they have reported a Niagara trial, which is a phase 3 study, where they have added durvalumab to the neoadjuvant cisplatin-based chemotherapy, and that has shown to improve the overall survival and event-free survival in those patients after cystectomy. But it's still not the standard of care. It was very recently presented. So I'm just going to briefly go through all these trials here. The ESMO guidelines recommend that the new standard of care is enfortumab vedotin plus pembrolizumab for first-line metastatic urothelial carcinoma. And if the patient progressed after this, then you give platinum-based chemotherapy or erdafitinib in those patients who have an FGFR positive disease. Those patients where they cannot have enfortumab vedotin because it's not available, or where patients have hypersensitivity or patient have uncontrolled diabetes, in that case, you should be giving platinum-based chemotherapy, more preferably cisplatin-based chemotherapy, which can be either cisplatin-based chemotherapy followed by evolumab or cisplatin-based chemotherapy with the nivolumab in combination can be given. So in beginning of this year, the NCCN guideline recommended all those as a preferred treatment. If they can have cisplatin chemotherapy, they should receive gemcitabine plus cisplatin followed by evolumab, dose-dense MVAC chemotherapy followed by evolumab, or cisplatin plus gemcitabine plus nivolumab followed by maintenance nivolumab, or pembrolizumab plus enfortumab vedotin. All those were preferred regimens in January 2024. By April 2024, the guidelines changed. Now the preferred treatment is pembrolizumab plus enfortumab vedotin as a preferred treatment. And if you cannot give enfortumab vedotin, or if it is not available, then you consider cisplatin-based chemotherapy followed by evolumab, or in combination with the nivolumab. Dose-dense MVAC followed by evolumab can also be considered for those treatment. So why cisplatin? Because we have studies showing that cisplatin-based chemotherapy is superior to carboplatin-based chemotherapy. And as we stand, most of the countries in the world still do not have enfortumab vedotin, or patient cannot afford enfortumab vedotin, which is very expensive. And that is why the cisplatin is still the standard of care. And it has shown in phase 3 studies, as you can see here, gemcitabine plus cisplatin, objective response rate of 49%, complete response is 12%. dose-dense MVAC, which is quite toxic, but response rate of 72%, complete response is 25%. Overall survival is similar in both these studies, and that is the reason all over the world, the oncologists would prefer to give gemcitabine cisplatin with much less toxicity and similar overall survival as compared to the dose-dense MVAC. Comparing it with the gemcitabine and carboplatin, much inferior. Objective response rate of 36%, complete response is only 3%, and median overall survival of 9%. So if you can use cisplatin, you should be using cisplatin rather than carboplatin in those patients. Here, I'm showing you again the same thing. Cisplatin combinations are much better in terms of responses as compared to carboplatin or immunotherapy alone. But those patients who cannot have cisplatin-based chemotherapy, then carboplatin-based chemotherapy is better than single-agent pembrolizumab or atezolizumab alone. The pembrolizumab or atezolizumab are approved with the objective response rate of 29% and 24% as a monotherapy in those patients who cannot have chemotherapy or platinum-based chemotherapy. So the first trial which led to approval of the immunotherapy was Javelin 100 study. So this is the study where patients have received in metastatic urothelial carcinoma platinum-based chemotherapy. They have given either carboplatin-based chemotherapy or cisplatin-based chemotherapy, and if they have not progressed, then only those patients were randomized to receive avelumab as a maintenance therapy or best supportive care alone. The primary endpoint was overall survival, and it was significantly better. So initial analysis in 2019 reported overall survival of 21.4% with avelumab as compared to 14 months for best supportive care alone. Similarly, in 2021, long-term follow-up reported median overall survival with avelumab of 23.8 months as compared to 15 months with no maintenance therapy. Hazard ratio was 0.76. So this became a new standard of care in those patients who received platinum-based chemotherapy and those who did not progress. Either they have responded or who have stable disease. After that, their overall survival is this much. So remember here, this overall survival is after randomization of finishing chemotherapy. So they have not included those 6 cycles. So their survival probably is longer, because these are the patients who receive chemotherapy of 6 cycles and then randomized. So 23 plus 6 months of chemotherapy probably is the right overall survival for those patients. So overall survival benefit was seen in all groups of patients, which I'm not going to go in detail of the subgroup analysis. And then progression-free survival, again, in PD-L1 positive disease and overall population, this has been shown. So you don't need to do the PD-L1 testing to give the maintenance therapy. So platinum-based chemotherapy is a good idea. And also immunotherapy, we have seen avelumab improves the overall survival. So that is the time when we thought that we should be combining immunotherapy with the chemotherapy. And so Keynote 361, which tried to combine pembrolizumab plus gemcitabine with platinum-based chemotherapy, cisplatin or carboplatin. The study was negative. So no improvement in progression-free survival or overall survival. So that never became a standard of care. Then IMvigor 130, again, similar study, but they used atezolizumab with platinum-based chemotherapy. Study again was negative. So when you use a combination of immunotherapy with platinum-based chemotherapy, both these studies were negative, and that never became a standard of care again. And then we have the Danube study, which tried to combine durvalumab plus tremelimumab. Again, was a negative study, and that again never became a standard of care till Checkmate 901, where they combined nivolumab with chemotherapy. Now, the difference between these studies is that the other studies have used platinum-based chemotherapy, while Checkmate 901 used only cisplatin chemotherapy, cisplatin plus gemcitabine with nivolumab, and the study became positive. And that is why I am saying, if you can use cisplatin, you should be using cisplatin rather than carboplatin-based chemotherapy. So Checkmate 901 was presented in ESMO, and that led to approval of this combination of cisplatin with gemcitabine and nivolumab. So first-line treatment for metastatic urothelial carcinoma, they randomized patient to receive nivolumab with cisplatin-based chemotherapy versus the control arm of cisplatin plus gemcitabine. Those patients who received nivolumab had maintenance therapy with nivolumab. The primary endpoint of overall survival and progression-free survival. The primary endpoint of overall survival was significantly favoring using nivolumab with cisplatin-based chemotherapy. You can see here median overall survival of 21.7 months versus 18.9 months for cisplatin-based chemotherapy, hazard ratio 0.78. You remember when we use chemotherapy, platinum-based chemotherapy followed by evolumab, the median overall survival was 23.7 months. Here we are saying 21.7 months, but this is from the start of chemotherapy because here they did not select patients who were responders. In the Javelin 101 study or Javelin 100 study, they only selected patients who were responder to chemotherapy. And then from randomization, they are saying the overall survival was 23 months. Here they are from the start of chemotherapy, 21 month was the overall survival or median overall survival. Again, the subgroup analysis for overall survival is favoring nivolumab plus cisplatin and gemcitabine in almost all groups of patient. Progression-free survival, again, was favoring using nivolumab with cisplatin-based chemotherapy, hazard ratio 0.72. The subgroup analysis like overall survival, almost all groups of patients, that is regardless of the PD-L1 expression, age, or metastases, liver metastases, all these patients favored nivolumab adding to cisplatin-based chemotherapy. The objective response rate of 57.6% reported in this study when we used nivolumab with cisplatin-based chemotherapy, and with 21% complete responses as compared to 43% objective response rate with chemotherapy alone. Median time to response was 2 months in both these arms, either chemotherapy alone or when you add nivolumab to chemotherapy. And median duration of complete response here is significantly higher with nivolumab, 37 months as compared to 13 months with chemotherapy alone. The toxicity-wise, the toxicity was mainly seen with chemotherapy, and you can see mostly hematological toxicity, and most of them were either grade 1 or grade 2. So Checkmate 901 led to approval of now nivolumab with cisplatin and gemcitabine because it has shown to improve the overall survival, progression-free survival, and complete response rate was significantly higher. Those patients who responded or duration of complete responses was more than double or nearly 3 times as compared to chemotherapy alone. Then came the study subgroup analysis where they looked into those patients who have lymph node only disease. And you can see here, this was the overall population. As we mentioned, the objective response rate was 57.6%, but patient who had lymph node only disease, the objective response rate was 81% with 63% complete responses. So this might be an option in those patients who have lymph node only metastases. You might be curing these patients. Look at the complete responses of 63% when you give nivolumab with cisplatin-based chemotherapy. In those patients with lymph node only metastases, the overall survival median of 46.3%, 46.3 months with nivolumab plus chemotherapy as compared to 24 months with chemotherapy alone, significantly higher when you add nivolumab to chemotherapy. Then came this study, the enfortumab vedotin plus pembrolizumab in phase 3 study, which is EV302. It's a randomized open label phase 3 study where patients with metastatic urothelial carcinoma were randomized to receive enfortumab vedotin, which is an antibody drug conjugate in combination with immune checkpoint inhibitor, pembrolizumab. And then the control arm was gemcitabine with platinum-based chemotherapy, cisplatin or carboplatin-based chemotherapy. Primary endpoint of overall survival and progression-free survival was in the study. So this study have included almost all patients. You can see here more than 30% patient had an upper tract disease, which usually have a poor prognosis. more than 70% patient had visceral metastases, and they have included patient with lung metastases, liver metastases, and bone metastases. If you remember, initially I've told you patient with liver metastases and bone metastases usually behave very bad, and they are poor responder to the chemotherapy treatment, and there are nearly 40% of those patients who have bone and liver metastases. They have included patients who have PD-L1 expression of more than 10 or less than 10 in the study. So progression-free survival was the primary endpoint, and you can see significantly higher. Look at the curves. So by 2 months, the curves get separated, and it is separating significantly from each other. Hazard ratio of 0.45 favoring using EV plus pembrolizumab, median of 12.5 months for EV plus pembrolizumab as compared to 6.3 months for chemotherapy alone. So subgroup analysis, regardless of the age, regardless of the performance status, upper tract, lower tract, liver metastases, PD-L1 expression, cisplatin eligible or ineligible, all have similar benefit favoring EV plus pembrolizumab as compared to chemotherapy alone. Overall survival, again, look at the curve separating immediately and remain so with a hazard ratio of 0.47. And the median overall survival for EV plus pembrolizumab was 31.5 months as compared to 16 months. So nearly doubling of the overall survival when we are using EV plus pembrolizumab. So more than 17 months benefit of the overall survival. And that is the reason now all the guidelines say to use EV plus pembrolizumab if it is available and if the patient can have it rather than giving chemotherapy in first line. This benefit in overall survival is seen in patients who are eligible for cisplatin, and even in those patients who are not eligible for cisplatin, the benefit is seen in patients who have high expression of PD-L1 and who have low expression of the PD-L1. Subgroup analysis for overall survival, like progression-free survival, is all patients it favor EV plus pembrolizumab as compared to chemotherapy. And look at the objective response rate is nearly 70%. It is more or less similar to the cisplatin-based chemotherapy, and with the 30%, nearly 30% patient would have complete response, which is very good responses for patient with metastatic urothelial carcinoma. As we have been saying, these are the patients with very poor prognosis, but now we can literally cure the 30% of these patients. And you can see here complete responses of 29.1% with EV plus pembrolizumab as compared to 12% with chemotherapy alone. Progression of disease was reported only in 8.7% of patients in EV plus pembrolizumab arm as compared to 13.6% in the chemotherapy arm. So is it more toxic? Well, generally less toxic than chemotherapy. You can see here anemia, neutropenia, thrombocytopenia were significantly higher in the patient who received chemotherapy as compared to EV plus pembrolizumab. So 27.7% patient has serious treatment-related adverse event with EV plus pembrolizumab arm, while 20% in chemotherapy arm. For patient who received EV plus pembrolizumab leading to death, there were 4 patients died, while 4 patients died in the chemotherapy arm again. So more or less similar or toxicity as compared to chemotherapy. The toxicity which are well known with the enfortumab vedotin is skin reactions and peripheral neuropathy, which is, you can see here, more than 60% patient reported some sort of neuropathy or skin reaction. But if you look at the grade 3 or more, it was 15% skin reaction, while 6.8% peripheral neuropathy reported. Apart from that, hyperglycemia of grade 3 and more reported in patient who received the enfortumab vedotin. So that is why if the patient have an uncontrolled diabetes, you should not use enfortumab vedotin in those patients. So the results from EV302 median progression-free survival of 12.5 months versus 6.3 months has a ratio of 0.45 favoring to use EV plus pembrolizumab. Median overall survival of 31.5 months versus 16.1 months has a ratio of 0.47, again favoring to use EV plus pembrolizumab. So EV plus pembrolizumab is the new standard of care, now recommended as a preferred treatment by all the guidelines, if it is available and if the patient can have it, or if they can afford it. If those patients who cannot afford it, then they can receive cisplatin-based chemotherapy. And this EV plus pembrolizumab is regardless of the PD-L1 expression, regardless of the cisplatin eligibility, showing significant improvement in overall survival, progression-free survival, and objective response rate is more or less similar to cisplatin-based chemotherapy. So Javelin 100 led to approval of a maintenance evolumab. The results were positive, but remember, they have seen the overall survival, or they have randomized patient, only those patients who did not progress on platinum-based chemotherapy. They have included patient with carboplatin and cisplatin-based chemotherapy. Checkmate 901, they use only cisplatin-based chemotherapy with nivolumab, and their overall survival is from the start of chemotherapy. They use 2 years of maintenance nivolumab. EV302 have used the maintenance therapy till progression of disease, so significantly more costlier, but looking at the results are significantly better in terms of overall survival, and progression-free survival has a ratio significantly better than the other studies. But this is not the direct comparison. I'm just putting numbers side by side. Objective response rate is for EV plus pembrolizumab is more or less similar to the chemotherapy. You can see here, as we've been seeing, the chemotherapy have very high response rate, but EV plus pembrolizumab is more or less matching that. So now enfortumab vedotin plus pembrolizumab is the new standard of care as a preferred treatment in first line. Those patients who progressed after first line platinum-based chemotherapy, sacituzumab govitecan, or erdafitinib for those patients who have an EGFR mutation present. Those who does not receive the treatment, those treatment in second line can receive in third line, or so on. So just to summarize, EV plus pembrolizumab is the new standard of care regardless of the cisplatin eligibility. Those patients who can have cisplatin can receive nivolumab plus cisplatin-based chemotherapy. Those patients who receive just chemotherapy, then they can have maintenance of evolumab. And those patients who cannot have platinum-based chemotherapy, then atezolizumab or pembrolizumab can be given. So very briefly, I will just mention a few slides on our recent publication, because I'm saying that cisplatin should be used if you can use. So can we use cisplatin in most of our patients or all of our patients? So we just did a study to look into it, because we know that the cisplatin-based chemotherapy is much better than carboplatin-based chemotherapy. The combination we are using is gemcitabine plus cisplatin, which is every 3 weeks, and the dose we use for cisplatin is 70 milligram per meter square. For dose-dense MVAC, we are using 2 weekly, and MVAC is using 4 weekly. The dose is 70 milligram per meter square. So this is the dose, 70 milligram per meter square, which patient cannot tolerate, and we cannot give cisplatin to more than 50% of the patient. But if we split the dose, this 3 weekly dose into day 1 and day 8. So rather than giving 70 milligram per meter square, if we give 35 milligram per meter square, most of the patient would tolerate it. I've shown you this slide because cisplatin is better than carboplatin, so we should be using cisplatin based chemotherapy if we can, rather than chemotherapy, immunotherapy or carboplatin-based chemotherapy. For cisplatin eligibility, we are using the Galsky criteria, which is a reduced creatinine clearance of less than 60, performance status of more than 2, heart failure of class 3 or more, grade 2 of neuropathy, and hearing loss. For carboplatin-based chemotherapy, we don't have a very good criteria, but Gupta et al. Has tried to define that as performance status of 3 or more, creatinine clearance less than 30, grade 2 neuropathy, and heart failure of more than 3. They should not be using carboplatin-based chemotherapy. How about split dose cisplatin? We do not have any criteria, but ESMO guideline recommend performance status of 0 to 2, creatinine clearance of 50 to 60. We can be using cisplatin-based chemotherapy. So we published very recently this paper, basically asking the oncologist about these three different regimens. Full dose cisplatin, which is 70 milligram per meter square, and split dose cisplatin, which is 35 milligram per meter square over 2 days, and carboplatin-based chemotherapy. So we wanted to see what criteria they would prefer to use these chemotherapy. So we did a survey-based study, and 136 oncologists from 21 countries have participated in it. The criteria we used was creatinine clearance, performance status, neurotoxicity, hearing loss, heart failure, and hematological parameters, which was not used by Galsky. So these are the countries where our oncologists have participated, mostly from the Middle East. And the reason for selecting these, because these are the countries where we wanted to see the practice, and we are using mainly the platinum-based chemotherapy here, mostly medical or clinical oncologists, but there were radiation oncologists and other oncologists too. So we asked the question for the full dose cisplatin, what is the criteria our oncologists would use, and they would prefer the same criteria as Galsky's have used for full dose cisplatin-based chemotherapy. And you can see here, creatinine clearance of more than 60, performance status of 0 to 1, neuropathy grade 1, hearing loss grade 1, heart failure class 2, and cardiac ejection fraction should be more than 50 before they considered the dose of cisplatin as 70 milligram per meter square, which is similar to the Galsky criteria. Then we ask about the hematological parameters, and more than 90% of the oncologists preferred to use the hemoglobin of more than 11, platelets of more than 100, and neutrophil count of more than 5 to give 70 milligram per meter square of the cisplatin. When we use cisplatin, the split dose cisplatin criteria, the oncologists are quite much relaxed about giving split dose. So creatinine clearance of 40 to 50 is okay with them. Most of them just said performance status of 2, neuropathy, hearing loss of grade 1 and grade 2 is even okay, heart failure of grade 2, class 2, and heart failure ejection fraction above 40 is acceptable to use for split dose cisplatin-based chemotherapy. Again, they are more relaxed in hematological parameters also. Then we ask the same question about carboplatin, and they are saying the criteria is more or less similar to the split dose cisplatin, except the creatinine clearance is more relaxed for carboplatin, is more than 30, while split dose cisplatin is more than 40. Apart from that, all the other criteria is the same. So that means the oncologists who are using carboplatin-based chemotherapy, they believe that the same patient can be using split dose cisplatin-based chemotherapy rather than carboplatin-based chemotherapy if their creatinine clearance is more than 40. That is the only difference which the oncologist would prefer. Here, the creatinine clearance is more than 30 for carboplatin, while he is more than 40. While the full dose, the Galsky criteria is considered as the standard of care. So our study highlighted that we can increase the number of our patients who can receive cisplatin-based chemotherapy, because still the EV plus pembrolizumab is not available, and we are using platinum-based chemotherapy. I would encourage you to use more of the cisplatin-based chemotherapy because it is superior than carboplatin-based chemotherapy. And we can use it in more patients if we give split dose cisplatin-based chemotherapy. As you've seen, most of the oncologists believe that if we are using carboplatin, we can use split dose cisplatin in those patients, providing they have creatinine clearance of more than 40. Thank you very much.
Thank you. That's great, Dr. Faisal. It's really, really informative session. So we've got one question in the chat box. Do we need PDL1 for EV Pembro? PDL1 testing?
No PDL1, no cisplatin eligibility. All patients are eligible for EV plus pembrolizumab. We can give it, if it is available, we can start it from the start.
Yeah, I hope in the UK there's a meeting in March 2025 and it will come in June 2025. So let's see. So with regards to EV Pembro, because pembrolizumab with combination chemo was negative previously in 2020, is it the effect of EV, or is it the effect of because of this enormous, like miraculous, I would say, difference in overall survival? So because previously, Previously, pembro was negative with combination chemotherapy, I believe.
Yes.
Yeah.
So as I mentioned to you, the pembro and atezolizumab studies, they have included patients with carboplatin also. A significant number of patients receive carboplatin, and that is one of the reasons the Checkmate 901 have excluded patients who are on carboplatin. They just use cisplatin, and that's why the result become positive. If they would have used the pembrolizumab with cisplatin-based chemotherapy, I'm pretty sure the result would have been different.
Great. There was another question previously. I think I would like to ask that. So can you use IO plus TKI in patients with the heart failure, ejection fraction less than 30%?
For renal cell carcinoma, we are talking
Yes, for
about?
renal cell, sorry. Yeah, so we missed that question. So
Yes. So ejection fraction of?
30% or less.
Yeah, so this is a tricky question specifically for TKI. I usually avoid it. So if somebody who has severe heart failure, so TKI usually even the immunotherapy is very difficult to use in those patients, but specifically TKI is very difficult. If you have to use it, you have to use it with caution and with the reduced dose. I will use half the dose, but preferably either use single agent rather than combination, because that can be detrimental for those patients. So, and if you are using it, use it as half the dose. Cabozantinib have been used in lower dose, but with caution.
All right, just one more, and this is the last question. So, would you choose Nivo plus Gemcis or Gemcis followed by Avelumab if you cannot use EV Pembro as first line?
Yes, it's a very good question, actually. So which one would you choose? I think the both results are positive and similar, although the design of the studies were different. It depends on the availability of the drugs. Like here in our center, all the drugs are available, but we are not allowed to give nivolumab with the chemotherapy. So if we are giving chemotherapy, we should be giving nivolumab as a maintenance therapy. So it depends on your the hospital or your setup where what is approved. But there is no difference between the two studies as such. Both are positive and similar sort of result. It's just the design of the studies were different. So you can use either of those. There's no direct comparison.
All right, that's great. Thank you. So I think this was a very good session, and as long as no one has got any more questions, so we will wind up this session now. And thank you so much, Dr. Faisal and Dr. Tirmizi, and hope to see you again at some point.
Thank you very much. That was lovely.
Thank you, Faisal. Thank you, Iftikhar, for chairing the session. It was lovely. In 1 hour's time and 1.5 time, the whole of urology has been reviewed. Medical oncologist. It's an excellent talk. Thank